Okay. Well, welcome everyone to ACME's stakeholder meeting. As you know, we try to bring in special speakers related to behavioral health issues. And this month, we're going to hear about Schizophrenia and Psychosis Action Alliance by CEO Gordon Levine and Linda Mims. So Gordon joined the Schizophrenia and Psychosis Alliance Action as CEO in November 2020. Previously, he was Executive Vice President of Operations since September 2018. And before joining this organization, he held executive management positions with a lot of leading nonprofits, including Alzheimer's Association, the ALS Association, the Autism Society of America, coordinating, executing strategies to accelerate organizational growth. And he had earned his BS in psychology from Lewis and Clark College and Masters of Education from University of Vermont. One thing to note, I mean, you have a lot of experience in the other chronic illnesses. So that brings a lot from that, all the other medical conditions. And Linda Mims has been an advocate to reform public policy, law, insurance, and treatment protocols for people living with serious neurobiological brain disorders for over 12 years. She began her career as a lobbyist on Capitol Hill for Xerox, moved to working on U.S. State Department in Boston, and then as U.S. Senator Alan Dixon's government affairs legislative analyst assistant in Chicago and Washington, D.C. As a creator and manager of public relations and employee communications department for the Quill Corporation. Linda has authored and edited 7 informational books and manuals on business productivity with over 100 articles and business tips published nationally in magazines, newspapers, newsletters, and catalogs. Been a featured speaker at several meetings on Capitol Hill. Others, again, you could go on and on. Linda earned an MA in public policy from Duke and a BA in anthropology from Lawrence University. And she is vice chair of this alliance. So with that, let me turn it over. If you have anything to share, go ahead and share. I activated that and gave you sharing privileges.
Thank you, and good evening on the East Coast, where it is very windy, very wet, but there is no snow. So I'm envious of Linda's San Diego environment right now, but really grateful for the opportunity to be here. We are very aware of the work that you're doing in Arizona, and many faces on this call are involved with so many initiatives and programs throughout the United States. So first and foremost, thank you for all that you're doing. We as an organization absolutely believe that we cannot do anything unless we are collaborating and working in tandem wherever we can. Our fundamental belief about the system of care for people living with schizophrenia, but broadly speaking, most forms of mental illness, the healthcare system is broken and fragmented. The personal, familial, societal impacts are often broad and devastating, and many of you know exactly what that means on a daily basis. So we're grateful for the opportunity to tell you a little bit more about the Schizophrenia and Psychosis Action Alliance. And maybe Linda, I'll turn it to you for intro, and then we're happy to give you more perspective and areas of potential collaboration.
Again, thank you. I want to reiterate, thank you so much for asking us to come and present. I so highly respect your organization and what you're doing in Arizona. And I've followed you for many years. You know, I've been on many of your wonderful, they're not really Zoom, I guess Zoom casts during the lockdown, and learned a lot and wished that you guys were over here in California, because you could do some work over here and help us out. But one of the things about our organization is we look at the issues in several different, through several different lenses. So we look at research, advocacy, education, and we practice care initiatives. So we we are big proponents of research to help improve treatments for this disease of schizophrenia. We also are highly supportive of bringing up the caregiver concerns and the caregiver voice in initiatives that we participate in. We had a session with the FDA recently, well, about a year ago, Gordon, several months ago, where people that are living with the illness and the people that are caring for those people were able to voice their concerns about treatments to the FDA and also talk about, the side effects that they have, what they'd like to see in future treatments. And along those lines, we also participate in research, and we're on the NIH Biomarkers Committee. We're always looking to see what route can we go to develop new and more effective treatments, because we all know that the treatments we have now are hit and miss at best. And it's so individualized. And since we don't know all of the root causes, obviously, and the genetics involved in schizophrenia, it's very hard to just focus on one treatment for everyone. It doesn't work that way. So that's one thing I'm very excited about with our organization. But my real passion in what we do is also the advocacy part, because many of the barriers to care, and this is a sad thing, the very sad thing, is that it takes 10 years from starting of symptoms to get a diagnosis on average for people. And the longer they are in untreated psychosis, the more brain damage and disability occurs. And they're not allowed their chance to have a full recovery or a more robust recovery. And that involves a lot of the laws that we have on the books in every state and across the country that don't view this brain disease as a treatable condition, chronic condition. So if we're not viewing it that way, and the legislators that are developing the rules, so to speak, on who can get treated and when, and if they don't understand the number one neurological symptom that prevents people from voluntarily seeking care, anosognosia, which goes hand in hand with 57 to 98% of cases of schizophrenia, then, what are we going to do? These people are left as being trapped in their own brains unless they get help. And if they need help involuntarily, then they need help involuntarily. But we have a lot of ideological discussions in our country because, first of all, the people do not understand the disease. So education is a huge part of what our organization does. And it's not just educating the public, it's also educating doctors and clinicians and people who are caring for our people who don't really understand the disease and therefore cannot give a gold standard of care. We don't really have a universal gold standard of care practices across the board for our population, which is very concerning. And, we always think too of the people that are living with the illness. Just think about this. The loneliness is one of the hugest problems with people who live with schizophrenia. That, I think, Gordon, it's second to financial issues, but loneliness, the high suicide rate. And think about it, if you were a person that was living with this illness and you thought it was hopeless, that you were never going to get any better, that you could not get into the treatment you needed to start on a path of recovery. So on that note, I'll pass it back to Gordon.
So the list of barriers to effective treatment and care are extremely long. Our starting point, as I mentioned in the beginning, is that the entire system is broken and fragmented. Technically speaking, there is an integrated standard of treatment and care for people living with schizophrenia. It's a very well thought through 160-ish page document that the American Psychiatric Association put together with the input of many, many individuals and clinical experts. The problem is it's not being followed. And finding a clinician, whether you're in Manhattan or rural Wisconsin, is extremely difficult. So how is it that we navigate this fragmented and broken system? How do we find a doctor who is willing to treat schizophrenia? And if you can somehow find a doctor and get a proper diagnosis, which often, people on this call know this very well, you typically get several misdiagnoses first.
Mm-hmm.
You typically start on some type of therapeutic approach, and then you get taken off of it and you switch several different times. You endure several side effects, issues, starts and stops, and all of the interim transitions that your body goes through with starting and stopping. Assuming you find a doctor, getting coverage, actual payer coverage, is also an extremely big challenge in this condition. So all of us are needed in very meaningful ways to figure out where can we improve this system. And it's not just the laws and the policies, all of that is a major barrier to what's needed. But we need more people to go into this field. We need more doctors who are willing. I mean, if this were cancer or heart disease or pick a condition, it would be completely unacceptable. And somehow we have allowed it to be okay, this status quo, which is horrific, to be acceptable. And our organization, so many of you and other organizations that we partner with every day, are standing up and really trying to find a better reality, because what this current status quo is unacceptable.
Yes, and I did want to say, I mean, I don't want to switch too quickly from what we're talking about, but I know you had a lot of questions about disease classification. And this is an area where our organization commissioned a study to determine whether reclassification of schizophrenia from a behavioral to a physical neurodevelopmental disease would result in better care for people with schizophrenia. And believe it or not, the study concluded that it would have minimal impact on treatment outcomes for people with schizophrenia. But it did suggest that reclassification could improve understanding of the disease and reduce stigma. And Gordon can probably talk a little bit more about this, but our organization has petitioned the World Health Organization to update its International Classification of Diseases, ICD, to recognize the high prevalence of the symptom that is the most common barrier to voluntarily seeking care, anosognosia. So, Gordon, if you want to add into that.
So interestingly, to get in the weeds for a moment or two, the World Health Organization administers a program called the ICD, the International Classification of Disease. And there's hundreds of codes, billing. It ends up leading into a billing code. And why this matters is that every condition has this code that medical professionals use when they are treating an individual for whatever condition. They get, you probably all are familiar, you get a prescription or a bill of service for a medical office visit. And it usually has like a 4-digit code with numbers. That is an ICD code. And in the United States and different jurisdictions around the world do this slightly differently, but those codes roll up to prevalence. And if you can't track the number of individuals who are being diagnosed with a certain condition, you don't know what the prevalence is. So what our organization determined was that for schizophrenia, there's been a lot of updates to the ICD. There's been some perceptions and misperceptions about what is the current classification of schizophrenia. It is neurodevelopmental, it is neurodegenerative. We have not met a doctor who disagrees with that. We certainly have met individuals who do not fully understand what the ramifications of those terms are. But what we discovered was that anosognosia, right, which is one of the leading symptoms of people with schizophrenia, does not exist in the ICD in a full way. It certainly exists in a partial way. But we think you need to be able to track all of the symptoms and all of the related parts of a condition in order to get confirmation. And if there's no confirmation, then typically in the United States, payers, insurance companies, don't believe it's a real condition. So there's less incentive, there's less prevalence, so to speak, that the reimbursement should be provided at the rate that they really do need to be provided. That's a long-winded way of saying this matters, but it's not the entire solution. The entire solution would involve stigma, discrimination being removed, policies, ineffective discriminatory laws being removed, more providers being available, access to barriers that exist for existing treatments like clozapine and new treatments that are on the horizon being removed. So there's a long list of issues that we're trying to tackle in partnership with others.
I have just a comment, a question. First, I had sent some questions ahead, so I put them in the chat if you, the participants want to read. Second, if you would like to have a conversation with World Health and people that are working on the ICD and the ICD-11, which Jeffrey Reed, someone I know well, they're now trying to build mobile apps and do other things. But if you want to have a discussion with him on one of his boards, so I'd set up and you could state your case and reason why you think it should stand on its own and not as just a subsymptom of other illnesses. So let me know.
Thank you. Yes.
We have, now I'm not sure whether you want to answer questions as we go or wait till the end.
Happy to answer questions as we go.
Yeah.
So we have one in there. If it is classified, reclassified, the person could no longer receive behavioral health services in Arizona according to our statutes. And it seems that schizophrenia could even be a spectrum. So
yeah, absolutely is a spectrum disorder. And we are aware of some of the unique challenges in Arizona, that moving it from a so-called behavioral health designation to a medical designation. We understand that in Arizona, that could force some individuals to no longer be able to get the benefits and coverage that they currently have. That is absolutely absurd.
Yes.
And all of you who are working in Arizona with the legislature, this is something that you must advocate for, and we want to partner with you on. We can't find another condition that the same thing would be true. It's discriminatory and it's morally incorrect.
Yes, I mean, it's very, very frustrating for us because these are medical conditions. And in our country, they have been siphoned off to this behavioral health moniker, which most psychiatrists absolutely disagree with. And it's given the public and everybody the wrong idea about what the illness is. It's not choosing a set of behaviors. It's a brain disease. And we don't do anybody any favors by putting it off in this behavioral area where they are not equipped in behavioral health to actually address a medical condition like this.
Linda and Gordon, I have a question. I have heard that brain scans of people with schizophrenia are very different from the brain scans of neurotypical people. And A, is that your observation? B, why would that not be compelling evidence for making this a physiological medical disease?
So it's a great question. Again, with our clinical and scientific advisory board, the medical professionals that we interact with, I don't believe that there is disagreement that schizophrenia is a medical condition, a brain disease, a neurodevelopmental, and if left untreated, neurodegenerative condition. The issue is that the current system of care, if you're having a heart attack or a fear of a stroke, you get brought to the ER, you have a major workup, diagnostics, all kinds of tests. If you take your son or daughter, generally speaking, to the ER with a psychotic break, the same type of tests and workups and lab tests and blood tests that the other conditions provide do not take place for schizophrenia. That is what an integrated standard of care and comprehensive treatment protocol should have for people living with schizophrenia. You're lucky if you're not taken to jail. If you're suffering from some type of psychotic situation. That's
But
really
Gordon, one thing, a good clinician and a good emergency doc will run tests to rule out it's not from another organic position, something that could, and Chuck could speak to it better than me, but they do run tests to rule out that it's not other diseases.
Would
Well,
a brain
I will-
scan, in this instance, though, would a brain scan that shows a whole different reading be similar to a blood test or something else that kind of supposedly conclusively says this is a physiological issue?
I think those are for people that have had schizophrenia for a long time. I don't think
Yeah.
you're going to see it on onset, which is
Well,
when you
but-
really need to do it.
Well, okay, but for those who have had it for a long time, maybe for that segment of the population, it could signify this is a physiological brain disease.
Well, it definitely signifies it in the twin studies. You know, I don't know if you've seen the brain scans of identical twins, one with schizophrenia and one without. It's pretty in your face there that there's definitely something going on in the person that has schizophrenia versus the twin brother or twin sister or whatever. I mean, same sex twins. That there is something wrong, that it is physiological. But whether or not, I don't know, and Chuck could speak to this, whether or not the entire medical community sees it that way is a different issue. And most of the time too, people that are getting schizophrenia and they have anosognosia, I mean, I can just speak for my family. Our family member wanted proof. He said, well, the blood test didn't show anything. You know, and at that point, the brain scan didn't show anything because it was early on. So we're not there yet on the diagnostics. But you're right, Dick. You're right that scans, and I think that the future potential of scans is going to get better and better the more we learn about brains. Chuck, what would you say about that?
You're on mute.
It's an interesting, this whole conversation is interesting. You have to understand that there are all different kinds of brain scans. So sometimes some brain scans, most of them are done by taking a picture of the brain at the time or assembling a picture, a static picture of the brain. In those kind of brain scans, you're looking at the anatomy of the brain. And it's well known, for example, that if you take a picture, say what you were talking about, Linda, in identical twins, one of which will have schizophrenia, and they've had them for many years, you can see there's actual structural differences. There's a wasting away of cerebral matter. I'm not exactly sure whether it's gray matter or white matter, but there is a difference in the brain scan. This is a picture down the road of somebody who's had schizophrenia when compared with somebody who otherwise is, quote, identical. Then there are brain scans that show the function of the brain. These are the functional MRIs, the fMRIs, and the PET scans. And they actually go to how the brain is functioning. And the way they measure that, by the way, is by measuring the cerebral blood flow to different areas of the brain and how that blood flow varies in people that have schizophrenia, for example. They do show differences. It's not located to one part of the brain, but it can be diffuse areas in the brain. So it's not like you're talking about one particular area. People have been trying to tease this out for some time now, so as to do exactly what you're talking about, which is to show that there's actually a functioning, that people with schizophrenia and other mental illnesses for that matter, like autism, actually have their brains functioning in different ways. Different areas of their brain so-called light up, which really means increased blood flow to the area. But the science of it, to my knowledge, has not advanced enough where we can use this as a tool. So even though Lori said before, what she said before was kind of a little bit off point, because I know that you, Gordon, were not talking about things that emergency doctors would do to rule out other causes of what might be causing a psychotic episode when somebody comes in. That is true. There are tests to figure out whether you have hypothyroidism or whether you have an adrenal gland producing epinephrine that's causing a state of what looks like psychosis. You can rule these things out, but there are no real tests, whether chemical or functioning images of the brain, that are good enough at this point to rule in schizophrenia. And that's all I can say about it at this point.
This is Mike Franzak. I'd like to talk about something that Gordon mentioned several times, and how the argument you're raising causes me some concern. First of all, I'm a psychologist. I believe there's no question schizophrenia and many forms of mental illness are brain disorders, okay? But you have mentioned several times that the integrated care model is the best practice model. On the other hand, your argument seems to be, let's put schizophrenia as a medical problem and not a behavioral health problem. And in fact, schizophrenia is a biopsychosocial problem. I mean, of course, medications have to improve. Of course, diagnostics have to improve. But medications are going to stop some of the symptoms, but they're not going to create functioning behavior. So I think rather to put it in, moving to put it in one bucket or another, each of those buckets are inadequate unless they're working together. And I think integration is the key to doing the best job of treating schizophrenia.
Yeah, I agree with the way you said that. That's an important characterization. It's the integration. And there's a whole element of schizophrenia that is environmental, that individuals don't fully discuss. And
sorry.
Go ahead, sorry.
I just want to add that that there's an effort in our area to provide a comprehensive service, especially for those who are in their first break. And we have specialized teams now responsible for taking care of those who are experiencing the symptoms early, and their trust is to make sure that that the diagnosis is good and the person is assisted in reducing the debility of the disease as much as possible. Yeah, that's all.
May I share something? This is Lois Costello.
Good, Lois.
Hi, I'm not on the screen. Can you hear me okay?
Yes.
Okay. I have something major that's been on my heart for a number of years because I've been dealing with this for over 20 years and it's blowing our family completely apart. I have severe depression. My daughter has it. My granddaughter has it. One son has schizophrenia. The other son has a severe anxiety disorder. We also plot. We also are very susceptible to having a stroke. One of my pregnancies could have turned out to be worse than what happened later in life. Could have had hydrocephaly, spinal bifida, etc. It is called MTHFR. Reductase is the last letter, and it is an enzyme that gets mutated, and that's what it is called, an MTHFR mutation. Both of my boys, as I said, are homozygous. Pardon me, I'm getting my words all wrong. I'm double heterozygous. My daughter's double heterozygous. I don't know what their father is, but he was a very lucid man, and all of a sudden he started to break. He'd been to Vietnam. Yes, he had post-trauma, but he hadn't broken. And in 99, he was 2000, he was diagnosed with schizoaffective disorder, post-Vietnam trauma, and severe depression, and he could hardly breathe. They found
Lois,
I'm just wondering, there be
a question for our speakers, or do you want to bring this up into the second part of the meeting?
Have you heard of like Dr. Fry at Barrow's Neurological Institute? He is a neuropsychiatrist. He is working with, or was working with, I don't know, autistic children from Phoenix Children's Hospital. And he had found that there is a cancer med that could get folate, vitamin B9, across the blood-brain barrier. And they were better in communication mainly. The other areas, not so much. So he's still, I guess, doing research. I wish I could talk to him. So it would shut me up finally. And I wouldn't care about this anymore. Maybe he could just tell me, this is a joke. All those articles on Google Scholar regarding this highly being involved in producing schizophrenia, bipolar, and severe depression. I'd like to know, are they a bunch of baloney? Folate is simply the organic word for vitamin B9. Inorganic is folic acid, which all pregnant women women get.
Have you, so Lois, so your question is if they are aware of whether MDHFR is also being looked at, or
Yes.
any of the genes? Okay, so let's stop with that now and let them answer that, and you can talk again in the communication.
Get there.
So I am not familiar with all of the details, but I'd be happy to address that offline if I find an update on that for you.
Have you address it? Because I think someone needs to tell me to let it go. I asked a pharmacist recently if he's a doctor chiropractor, I believe. He's got Seeking Health, and he has a 5 MTHFR with vitamin B12, and it is helping my daughter now. She's taking that. She has more energy. Anyway, I won't go into that.
Okay, thank you. Well, if we read in the chat,
norepinephrine, epinephrine, and serotonin.
Okay.
That's simplifying it, as I've been told. I'm an idiot. This pharmacist never heard of folate, never heard of MTHFR. Why on earth was I concerned about it? He didn't understand. And doctors that don't know, have patients with that, don't know what I'm talking about.
Hey, Lois, I can shed some light on this, and I can maybe touch base with you after. There is some correlation to a lot of genetic things.
I know. Yeah.
But there's nothing very definitive that we can't just take a genetic test to check for schizophrenia or these mood disorders like you've described. MTHFR, those variations that you described, are present in a large portion of the population,
Yes.
20 to 40%. So it's not a conclusive situation of, hey, that's the issue. Is it connected to some other things? Yes.
I have a question. We're homozygous. From what I've read on studies, the boys can maybe, if they can get hold of folate ever and get it across the brain-barrier barrier, it works about 20%. With me being double heterozygous, but yes, there are. At the time we found out we had factor V Leiden.
Hey, Lois, can we take this to the second half of the meeting so our guests can finish their discussion? Because once they leave, we'll have time.
Because it's contributing to autism too, and schizophrenia.
Fine.
It used to have autism
Shut her up. So it's okay.
concluded.
Go ahead.
I'm sorry. I'll let bye-bye.
Yeah, you do that.
Okay, so Gordon, Linda?
So I'm reading some of the chat comments, and there's several things that have come up. There's some questions about schizoaffective or bipolar features. I think one of the things that is important to point out, so our organization, Linda referenced it in the beginning, just over a year ago, we did a project in partnership with the Food and Drug Administration called a Patient-Focused Drug Development Meeting. It's been around for about 15, 20 years, and many different conditions partner with the FDA to elevate the voice of the patient so that the agency can factor the real-world evidence into decision-making for potential new therapeutics. So we did a several-hour meeting a year ago, November. And one of the key findings in our pre-meeting survey was the misdiagnosis. It's often the case that we hear, talking from both clinicians and those around the table, that individuals are typically misdiagnosed, usually with a schizoaffective, and I'm generalizing, but it's a broader category. So it's easier to lump into that designation to begin with. And over time, as the treatment progresses, it's usually refined into schizophrenia. Why that matters is that misdiagnosis, a lack of clinical expertise in what the underlying symptoms are, means that there's delay. There's delay in therapeutic benefit and psychosocial support benefit and all the wraparound supports. That's something that fundamentally needs to be addressed in medical education, provider education. And one of the things that we're grappling with, we're going to be doing an event in Washington, D.C. in May, and we're trying to bridge the divide between not only policymakers, but also the research and clinical communities. We've been told that the advocates need to play a larger role in helping providers and clinicians better understand the condition. And for the longest time, we've been under the impression that it's those with lived experience that need the providers and the clinicians to step up and to join the advocacy. And what we're realizing is we're both right. What we need is to bridge the two worlds. So one of the major initiatives we have going into the year is not only to remove barriers across the board, but also to bridge these divides. If you look at another example with disability rights, there's a lot of examples around the country of so-called forced treatment, which is interpreted as coercive treatment, really. And that's where the disability rights community gets up in arms, taking away an individual's voice from what their treatment options are. That is something that we think is a major issue. Obviously, many of you are involved with these around the country. It's fundamental. It starts with dialogue. And there are so many areas, and this is not a disability rights soapbox, but it's important to point out that the rights community does a ton in support of unsafe facilities. Whenever parents call on behalf of these concerns, it's the rights community that shows up and has a whole log of incidents. And there's been an established track record of fighting for better treatment. But there's this whole other dimension to it, which is not fully understanding the realities of these brain diseases. And what we've noticed in collaboration with some of these groups on a nationwide level is that there's a willingness to talk and to try to find some middle ground. Because if this is acceptable, this standard of care, then we have some real major issues as a country and a society. But there is a willingness we're seeing to bridge this divide. So in the months ahead, we look forward to keeping all of you updated on ways that we may be able to partner to have these dialogues and discussions. Because I know I've heard from people like Rachel and others in Arizona and California and everywhere across the country that these chasms are profound and are causing major breaking points in understanding and working towards solutions that we think we can effectively make some progress on in the months ahead.
I just want to add on to what Gordon was saying. So in California, we have attempted and tried to talk to our Disabilities Rights California several times, and they just are not. They view it in a very black and white, this one aspect of what they consider coerced care. And a lot of that, we have tried to educate them. But I think that if we had at the federal level, we had dialogue, and is what Gordon is talking about, that could drift down into the states. And we need that so badly, because these groups, what they do is they scare legislators. They scare the congressmen and the senators, et cetera, and the state legislators to put forth anything that might have like a locked facility, or, putting somebody into compassionate care involuntarily. And that is a major, major barrier for us in California to get people into the life-saving treatment that they need. So I am hopeful this year that our organization is going to have hopefully make some movement towards some compromise, or whatever you want to call it, understanding at the federal level, and then maybe that can drift down to the states.
We're going to be doing, this is not for full detailed public announcement, but I'll give you a sort of a brief, we're going to be doing a tabletop exercise with the disability rights leadership on what a better treatment protocol would look like, identifying where the current blockages are, current disagreements are, and to literally game plan if we were to do it a different way, and finding commonality, what that would look like. So if any of you are potentially interested in participating in a day-long tabletop exercise to try to find a better solution, send your contact information in the chat, and we'll circle back to you in a couple of weeks once that gets arranged.
We've tried with ours locally that are so opposed. I try logic like, do you not consider jail and prison a locked environment? So we're just saying it should be therapeutic and early, and not wait till that. I mean, we have many a time, but I'd be open to sitting in and trying to help.
Rachel, I see
Yeah.
your hand's been up.
Yeah, hey guys. So I've been wanting to, this has been on my mind all day, and wanting to tell both SNPAA and ACME about this. And you guys are all on the same Zoom. I'm so excited. So today there was a large number of mad moms that went to the Capitol, and there was a declaration made by State Senator Catherine Miranda about no more deaths for SMI. And on that note, you guys might recognize the name Crystal Fox. She's joining us tonight. Probably all of you have seen her story. I know you all have. And I was speaking, there was, of course, I'm shameless. There was, a legislator came by. Of course, I had to talk to her and speak with her and tell her about our cause. And this was Representative Travers. I'm not sure what district, but we were talking and eventually she was like, oh, you guys are against involuntary treatment, right? So the mental illness, support for serious mental illness, it's been so inundated by disability rights groups that every legislator assumes everyone's against involuntary treatment.
Yeah.
And so when I said, no, we want more beds. We want to remove the cap at the state hospital. We want more involuntary treatment services. We're all here because we couldn't get treatment for our kids involuntary. And she was so confused. So we've become serious mental illness and mental health and mental illness efforts have become synonymous with getting rid of involuntary treatment, such that I think legislators literally are confused by the messaging because they don't hear our voices ever at all loud enough and clear enough. They only hear these disability rights groups trying to shut down state hospitals. So anyway, how do we change the messaging to say, yes, involuntary treatment, locked facilities are needed. We've cut all of those out of the continuum of care, and it's a problem and it's dangerous. And we need this. They're not hearing it because they've been inundated by the other message.
We try to use examples. For instance, are we hearing from disabilities rights about people that have Alzheimer's that are in locked facilities for their own good, for their own safety and treatment? No. What about people that have Parkinson's psychosis? What about people that have had a stroke, that have anosognosia? I mean, this seems to be just centered on one group of people with these brain diseases. And, I don't know, after a lot of years of trying to educate in California, it's just not working. So, I'm hoping that having some movement at the federal level we may be able to utilize, but it's very, very frustrating. I feel your frustrations.
And I think in California, even when they say they want to do it, that what they do is they send teams out to people on the streets that are highly psychotic, and then they ask them, will you come into treatment? So and if they say no, they go away. So
that's right. They leave them.
Yeah.
They just leave them sick on the street. And I heard one behavioral health director in Orange County, and she said, well, sometimes it takes 40 times to get a person into care. Well, that 40 times translates into what? A year? And that's a year in untreated psychosis, more brain damage, etc. So we've got to change this.
Has there been any research done for why the disability rights organizations get more attention and in many cases are stronger, that people will listen, or legislatures will listen to them rather than those of us who are advocating?
I think the simple answer to that good question is that the quote disability rights umbrella is very broad and goes beyond just health conditions, let alone schizophrenia. I mean, it encompasses everything. And in current US statute, disability rights groups, many of them, get a lot of annual funding to be, they use the term PAs, to be sort of the on command, on watch jurisdiction reviewers of many different types of situations. So they're very embedded in US law, but also across many, many aspects of society beyond healthcare.
And therein lies the rub. They represent so many so many organizations that, you know, our little piece there, you know, they're misrepresenting us, and we're in California, our tax money is going to them. And then they are actively acting against the best interests of our children who are sick.
I also think it's a lot easier to argue freedom than it is to argue restricting freedom, even when it's appropriate. But I think you had a point earlier, you used the term, we're denying some people life-saving treatment by not providing the level of security they need to survive.
Amen.
I'd like to say something
Okay.
also. This is a very interesting situation. Usually when I look for befuddling confounds to a problem, it usually helps by trying to follow the money.
Mm-hmm.
Now, the interesting thing about this is that the short-term solution, the short-term answer to saving money is not to create very expensive treatments for people that you would just rather just sort of drift away and live on the street somewhere. So this really comes down to both governmental and institutional interests like those of the insurance agencies. But what is really crazy, and which we have, and something we have shown at ACME by creating the study that actually looked into this, and they're not the only ones, in the long term, society in general would spend much less money treating people with SMI if they treated them appropriately.
That's
And
right.
by appropriately, I'm talking about for those people that need to be in locked institutions for whatever period of time to make them undergo treatment that will help them, which in part hopefully reverses to a degree anosognosia, and that does happen. It's interesting to me that, but it's interesting to me that people can't look to the long run and how much money would be saved by actually doing this, which, by the way, is, as far as I'm concerned, the only way to appeal to legislators that are locked into this disability law group that would have you not treat these people because of the taking away their rights. It's really unfortunate that we have to go down the path of actually looking at the money in the system rather than doing the right thing by people who are actually sick people. And I feel bad about that, but I think, Linda, that I'm not so sure that I'm hopeful that federal measures are going to trickle down to California, to any state that'll help them, because my mind goes back to what the 2008 law for equity in insurance with respect to mental conditions and physical conditions was supposed to produce. And really, that law was a very weak law and really had to be ratified within the state to do anything at all. So
Good point.
I'm not really hopeful, but of course, do whatever you think is going to help.
I'm concerned that a federal solution might put clamps on all the 50 states on what they can and can't do, and make it more restrictive. Then we lose the laboratory effect of having 50 states who can try different approaches.
Well, I'm not thinking of putting clamps on anything. I'm just thinking of opening up a dialogue to get some understanding about the disease from the disability rights groups, so that they can understand what's needed to help these people get into recovery, and that some of the actions that they are taking are prohibiting that.
Most of these groups, they want the money for themselves, and that's a big part of why they're lobbying so hard against locked facilities, which locked facilities would cost money. It would redirect money away from them.
I'd
Don't
like
you
to,
think
you know,
also?
Linda, you made it just a comment, and this has just bothered the heck out of me, is just having that conversation with the civil rights groups and the advocacy groups for civil liberty rights, or ACLU, and how much conversation have we had with the advocates for trying to do the humane care and treatment for people with mental illness, but short of doing secure forced lockdown? I mean, have there been efforts in your circles where there's actually tried to be a dialogue? And what is the impasse? What's the logic behind that, as you said, with the Alzheimer's, that why we would not do this for their protection? What have you come across?
Well, in my work in my state as an advocate, I advocate to get really sick people into care. And most of the time, those people have anosognosia and they are never going to accept care voluntarily.
I see.
So I have families in my county calling me all the time. Their kids are on the street. They're disintegrating. I mean, you know, I would gladly, and I have actually talked to people in the DRC here, and they just, it's like a brick wall. It's like talking to a brick wall. So I think the families that have been advocating, some of them for decades in my state, they're advocating to get their kids into care. And the reason it's so hard is because of these issues we've been talking about, with this blanket view of any kind of compassionate involuntary care being coercive and evil. And we have several people in our state who were involuntarily hospitalized who now speak out and say that saved their lives.
Yeah.
And they fight for other
yeah.
people. You know,
I think that in general, the people that the disability groups talk to are peers that are recovered or not that as ill, as chronically ill. So I think that is part of it. And as far as making the argument of, we made it to the president of Mental Health America when he was out for a meeting several years ago. And we were having this debate over dinner. And I said, but what about if your mother has, Alzheimer's? He said, it's different. And I think Chuck argued too, and had to kind of agree with him. And I hated that he disagreed. He said that was like Alzheimer's, but like he was saying, as a physician, Alzheimer's always gets worse. Dementia gets worse. In mental health, it's not always worse. So that's why there's that, it's not equivalent.
I hear you. It's just amazing to me how we could all feel like we're so right and everybody else is so wrong. I mean, it just feels, yeah.
Well, I think it's because one size does not fit all. I've worked for the Department of Justice Civil Rights for the last 20 years. They're not out saying get everyone out of the hospital, secure hospital. They're saying get the people out of the hospital who don't need that level of care. Where the physicians in the hospital are saying they're good to go to the community, where the person is agreeing to go to the community, where the community has the resources to support the person. But we're arguing one size fits all. We need secure facilities. For who? For a certain select population. And
are top of mind. The governor, her goal to put some
I wouldn't say we're arguing one size fits all at all. We're arguing for the sickest piece.
I think the rights people are arguing one size fits all.
Oh, yes, I'm sorry.
They're hearing us as applying that we're going to just blatantly run around securing people when in fact it's really for a small targeted group.
Yes.
Chuck, you had a term for that, the smittens or whatever it was, the small group that need that level of care.
It was actually Dr. from,
Olson.
yes, it was actually her. And it wasn't Splinter, but it was something like that.
I'll make two points.
Yeah.
One, I didn't catch your name, the gentleman who just spoke, but you work in the Office of Civil Rights, which, by the way, administers HIPAA. And there is a major divide in this country over the HIPAA implementation interpretation. We might want to talk offline about some of those issues. But in our experience, the rights community, again, is interested in dialogue. And anyone who would like potentially to be involved in that tabletop exercise, please raise your hand. The other thing is that we have to find common ground. One issue that many of you are involved with is the current REMS that the FDA administers for clozapine. Disability rights community has been public in support of the work that we're doing to eliminate the burdensome REMS requirements for clozapine. That is an issue the rights community completely agrees with, that is wrong, that should be loosened up. So there is areas that we can find agreement on, and we think our strategy as an organization is let's find that low-hanging fruit first, and then work toward the harder issues where we think we have this major divide.
Thank you.
One
There are some-
challenge real quick that we have in Arizona is that, yes, there's some agreement that locked involuntary long-term acute treatment is necessary, but we have at least a 2,000 bed shortage based on our population. And as a result, dangerous to others, danger to self. Very sick, deteriorated people are simply not getting treated. And so the horrors of the last century of whatever abuses and corruption were happening in all the insane asylums, we're doing that far worse now in our jails and prisons.
Yes.
That's what's happening in Arizona. We
And
are
on the streets.
already history repeating itself, but in a much worse way because we decided to free everybody from the asylums. So
Way to put it.
One thing, just to be respectful of your time, we could talk. Let me know how long you have. We do have a good question in here from Crystal about autism, a comment and then a question. I'm not aware of Willowbrook, but maybe they are.
What's the
Yeah,
specific
you should be
question?
aware of Willowbrook. It was in Staten Island.
That's correct.
So do you want to ask your question? Crystal, do you want to explain so they don't have to go hunt for your
Yeah, I
comment
sent
and
this to
question?
Rachel not too long ago. Willowbrook was what happened with the developmental disability community. That's what established the Department of Developmental Disabilities. That was the initial spark. And it was, they investigated in Staten Island what they called a school for those with severe developmental disabilities. And Geraldo Rivera and the news basically went up against Willowbrook and showed all those horrors of, I mean, you can picture it the same as a jail cell, you know, people sitting in their feces, urine all over, unsafe, unclean conditions, no treatment, no care, no therapy. Just a lot of times they weren't clothed. And after they came in here, and Kennedy was part of this because he had a special needs individual. But basically that was the upheaval that developed the Department of Developmental Disabilities. It took years, of course, but that was the initial spark that started basically the civil rights and the treatment of those with developmental disabilities. And my question is that I see schizophrenia very much like autism. In fact, schizophrenia used to be called, or autism used to be called infantile schizophrenia because it has the same sort of symptoms, except for one starts at 2 and the other one starts at 22. So, and they go up and down depending on the care and the treatment and what they're getting. And so my thought, and I was curious to know what the Psychosis Action Alliance, what they thought about like comparing it with more like a developmental disability like autism or even cerebral palsy. I mean, I know that's got physical limitations, but again, those people, they improve and then they have other issues as they get older, same as schizophrenia.
Yeah, the autism example is something we've looked at very critically. There's a lot of parallels and intersection points, including the rights community in Willowbrook was instrumental in highlighting those atrocities and ensuring that they never happen again. The issue, though, is if you look at the treatment of autism, they did such an amazing job. And I used to work for the Autism Society of America. I can explain the whole Autism Speaks development with major media and the former chairman of NBC and how that whole world, but it was the parents. It was the parents that stood up and said, enough is enough. You know, we've got angry moms and angry dads. We don't have enough of them. And that movement came together and fought the systems of education to ensure wraparound supports were put in place in legislation. We haven't seen that happen for, quote, mental health in the same way yet. And obviously the level of funding hasn't happened at the state and federal levels yet for our condition.
Yeah, and I actually was part of all those like movements because I have 2 kids with autism. So, and then one with schizophrenia. So, I watched that movement happen, and it was the families, it was the parents, and it was fighting the school systems, and it was getting the ESAs and the wraparound services, and not letting legislation get away with mistreating kids by putting them in what they call a comfort room, which was a closet. And I'm wondering if we shouldn't, in some ways, go about schizophrenia in a very similar way.
Well, I like what you're thinking. And I will say that, you know, one thing that this brings up in my mind is we as caregivers, we don't have any kind of monetary supportive services for taking care of our loved ones in our homes, like people with autism do, or people that have an autistic child. My cousin has an autistic child and she has all sorts of supports in her home. I don't know one mom or dad with a child with schizophrenia that has any kind of that kind of financial and just, you know, laborious support in their homes. And that is not right at all.
No.
So,
Right,
and
that's
I know,
wrong.
yeah, that's wrong. And I know a lot of advocates that I work with, we do bring up autism when we talk to legislators and such in our state, but we're not there yet. And we're trying to be a big voice for our loved ones. But I don't know the statistics on autism. Maybe, Gordon, do you know how many people in the United States have autism? Because maybe there are more parents that can speak out about that.
Yeah,
Last one was 1 of 65, I think.
Yeah.
So they go down a little bit. Sometimes they're lower, 1 in 40, but usually it's about 1 in 60. And there is a lot of.
One of the really interesting things. So the federal law that went into place is called the Autism Care Act. And it's a bit controversial in the autism community because it finances the National Institutes of Mental Health to conduct research to reduce the incidence rate of and ultimately find a cure for autism. Now, the neurodiversity community is flabbergasted by this, that somehow they want to be cured or removed. And I'm generalizing. Schizophrenia, the neurodiversity community isn't as vocal as it is in autism, but the law did not change the designation of autism to become a neurodevelopmental disorder. That was left out. So they were able to get the entitlement, so to speak, through legislation, but they ran into this major political headwind once they tried to, quote, cure autism, because individuals on the spectrum of autism found that to be somehow discriminating against their individuality.
Yeah. One thing Dr. Mike has often said about behavioral health, and Dr. Mike, if I'm misquoting you, let me know. He said the problem with behavioral health agencies and advocates, they circle the wagons but then they shoot inside at each other. So that's the difference, that with mad moms of drunk drivers, they all wanted the same thing. Probably with autism, they wanted the same thing. But when you talk to different groups and they all are under the different label of behavioral health, some of them here in the Valley, peer and family, are all against most of what we are for. So I think that's
Really?
the confusion. Yeah. Mike?
No, that's it. They're go at cross purposes, and we never achieve anything. We just circle.
Well, and I think that's, sorry guys, but I think that that's kind of why I think schizophrenia isn't by itself like autism. It's it's not, like you guys were saying earlier, it's not part of the mental illness realm. Schizophrenia is like autism and kind of needs to be, or psychosis, not just schizophrenia, but any of that spectrum, I believe needs to be thought of as a developmental disability, not depression, not those other things, but schizophrenia. Sorry, my mom came out. We made the news again, guys.
Oh,
Good.
Yeah, supposedly
good.
we were on the 4 o'clock news. I haven't seen it yet, but we've been making the news lately. And Crystal, I'm so sorry that it took your kid dying the way he did for this kind of visibility to happen.
yes,
But, you
Crystal,
know,
so sorry for your
yes.
loss, Crystal.
It is interesting that when schizophrenia starts, it impacts, and Dr. Chern, who's a psychiatrist, and Dr. Franzak, who's a psychologist, but it impacts and often they're studied in their social emotional growth. So it is kind of like that. I mean, Dr. Chern, do you agree? Dr. Franzak, do you agree that it does stop the normal development?
By the time that
Absolutely.
you got so by the time the symptoms really become void, it said that the person is already delayed in a lot of other aspects of development, and so you see them slowly lagging behind their peers until the usual age of 18. The symptoms become void, and then that's the only time interventions really in our society are given. So already there's really a delay in their interventions that could possibly be done. Dr. Mike?
No, exactly.
Or if I could just add real quick, just because, I have 2 boys on the spectrum. One that was, always delayed, and then one that was progressing normally. And then at about the age of 18 months, just like you just saw this huge swoop of, regression in him. And it reminded me a lot of what I've seen, like, when I talk with Rachel and Crystal and we have conversations, it reminds me a lot of autism, where you have this person developing completely normally. And obviously the people with schizophrenia or bipolar disorder are much older. And then all of a sudden you just see this significant rapid decline, just like autism. They lose their ability to feed themselves, to be able to help with self-care, to even speaking. My child lost his words, and I'm like, oh my God, what's going on? And all of a sudden there was this swoop of care. I applied, and all of a sudden all these services and every doctor under the sun was willing to see my kid. And it's disheartening to see that that's not happening with our loved ones. They have to, horribly, tragically die or end up in our criminal justice system, and then they still don't get care. But if you got autism, oh, everyone's opening the doors, parents are getting paid to care for their kids at home because they recognize they can't work. And it's just, there's so many similarities.
Like Chick Arnold used to say, and he, it was a class action suit in Arizona. Serious mental illness is not a casserole disease. When someone finds out through the community that you're son or daughter has schizophrenia, they don't come over and do the casserole lineup to make sure you're eating. They kind of all quietly, leave you alone, think that you need. So it's different. So any last questions for Gordon and Linda? I know I think it's been a great conversation, and I don't want to take too much of their time up, but if you'd like to stay, please do. This is usually where we transition to the portion that families can talk to us about what they're going through, and we try to brainstorm and come up with. Oh, we do have Janina
Yes.
Rotaro. Yes.
Hi, I just wanted to add just a little bit about schizophrenia. There's a typical emotional and cognitive flattening in schizophrenia. So emotional flattening, basically, they're unable to experience the full range of emotions and express the full range of emotions, which obviously is going to impair their social interactions, interactions with family members and so forth, and they're not going to be able to read the cues from the people that they interact to respond appropriately. So, and actually there are studies that show that amygdala in the population with schizophrenia is hypoactive. So, and that's quite important to note. And yes, there's absolutely a stunted emotional development, if you will, in this population. Thank you.
Any other questions for Linda or Gordon?
Thank you, Linda. Good to see you.
Thank you so much. Thank you for inviting us. It's always a pleasure to come to one of your sessions.
Thank you.
Thanks, Linda.
Thank you, guys.
Take care.
Thanks.
Thank
At
you very
this-
much for attending, for doing this.
At this point, we'll turn off the recording